Hello, everyone. My name is Evandro Azambuja. I'm a medical oncologist from the Ruíz-García Institute in Brussels, in Belgium. And it's my pleasure to be here today with you to discuss about the ESMO 20 Educational Weekend. And this time we are going to focus in South America. And the idea of this is really to see what are the main points that you get from this ESMO 20 educational weekend and how you could translate this into your own country. And for this, we have four speakers today. Dr. Erika Ruiz-Garcia from Mexico, Dr. Martín Angel for Argentina, Dr. Leticia de Mattos-Arruda, Brazil and Spain, and Dr. Andrea Anampa-Guzmán from Peru. Just to highlight, Andrea is not yet a doctor, but she's a very prominent student, and it's very nice to see how the students are being engaged in ESMO activities. So the format of this meeting is each speaker is going to talk about 2 to 3 minutes, giving their highlights, what they found that could be very interesting. And I'm going to ask some questions to see how we can implement these new educational things in their country, or anyone can comment if they wish to. Let's start off with Dr. Erika Ruiz Garcia from Mexico, who is going to talk about how is the treatment of pancreatic cancer today, how there are new algorithms, how we can treat this very aggressive disease. Dr. Erika, the floor is yours.
Thank you so much. I'm very happy to be here with all of you, with my colleagues from Latin America, and of course with you, Professor Evandro. And well, I would like to talk in a few minutes about pancreatic cancer. We all know that this disease is a very lethal one, more than lung cancer. This has changed for lung because of the new drugs. And sadly, this is not true for pancreatic cancer. So at ESMO Educational Weekend last year, Dr. Trojan talked very important topics that I would like to talk with you. Why is this? Well, we all know that there are two main treatments for pancreatic cancer in advanced disease. This is the FOLFIRINOX and the gemcitabine nab-paclitaxel. We all know that these are the best treatments. For the first one, there is an overall survival over 11 months, and with the second one, it's over 6 months. The difference is that not all patients could go to FOLFIRINOX because they are not fit enough. So one study that Dr. Trojan showed us was a real-world data from US with over 4,000 patients treated with these two schemas. And it was very interesting to know that the treatment with FOLFIRINOX, the overall survival was 9 months instead of 11. Meanwhile, for GEM-NAB, it was almost the same, 6 months as in the trial. But I think that another important thing to say about these two treatments is that we can feel comfortable if we need to do dose reduction. Normally, as I already said, some of these patients come into the clinic in a very bad way, so it is not so easy to give full dose. So he also showed us very interesting data from a retrospective study and also from real world data in first line and second line, this second line with irinotecan. And he explained us and show us that the dose reduction doesn't mean less efficacy because people feel better and they do not have a lot of toxicity. And another important thing to say about these two treatments is that he showed us another very interesting German trial showing us that the quality of life, sadly, it doesn't matter which treatment you use to the patient, it's going to have a deterioration. It was very sad to know that even with GEM-NAB, that is not so toxic, at 6 months, most of the patients, 60% of those patients that got into first line at 6 months, they already have a deterioration in quality of life. And last but not least, it's important to say that we always have to think about the quality of life of these patients because even we have good drugs, normally they have a lot of toxicity. We all know the molecular testing, we have to do it for pancreatic cancer in advanced stage, But this is not so easy to do for all people. Normally it's because it's quite expensive, maybe because the deterioration of the patient. But if we know the molecular testing, some of these patients could have another kind of treatment. We all know that from the 100% of mutations, most of them belongs to KRAS mutation, and there is only the 12C that maybe could use a special drug. Other patients that do not have KRAS mutation, maybe they could have a DNA damage repair genes. So there are some drugs that they could help those patients. But I think it's not so easy, at least for Latin America and some other countries.
Thank you very much, Dr. Erika. Very, very nice. And indeed, pancreatic cancer is a very aggressive disease, and I agree, treatments are not so easy. Patients, they have a worse outcome. They tend to die early because of the disease. We made very few advances in this area. So it's really sad to see that many cancers, they had many improvements, but pancreatic cancer still remains an unmet need. You mentioned that they study with 4,000 patients look for different types of chemotherapy. And you mentioned also that sometimes patients, they already have a bad performance states when they start treatment. And you also mentioned about those reductions of chemotherapy. Do you think that the best strategy in those patients should be to start chemotherapy with a full dose and reduce it as needed, or to use another approach, escalonate treatment, to start with reducing doses and then increase if the patient tolerates? What is your opinion on that?
In the real practice, if we have a patient with an ECOG 0 or 1, normally we give the full dose. But for those patients that are ECOG 2, or maybe they have a lot of comorbidities, I really, in my practice, and I ask to a lot of my colleagues, normally we have a dose reduction. But we never go into an up or escalated after we see a benefit.
Mm-hmm.
So normally we stay with the dose reduction all over the time.
You also mentioned about genetic testing or genomic testing those tumors that is not so easy to do in your country. And you see many young patients on that you would like to test those tumors to find some mutations to give you access to new drugs. How is the percentage of young people compared to elderly people?
Yeah, very important question. The first one is that in Mexico we are able to do the genetic test, but it's quite expensive. So not all the people can afford because it's not reimbursed. That's the first barrier. And the second one about the young people, our data show us that at least 18% of the people with pancreatic cancer are under 40. We know that the younger pancreatic cancer, it used to be less than 50 years old, but I'm speaking about the less than 40 years old are 18%. So we see a lot of young people with this aggressive disease that even though that they come in a very good shape, normally the treatments do not do well. Our overall survival, even with the best treatment, is very low compared to older people.
Okay, thank you very much, Dr. Erika. Let's move to our second speaker, Dr. Martin Angel from Argentina. Thank you for being with us today, Dr. Martin.
Thank you very much, Evandro, and thank you very much as ESMO organizers for inviting me to this kind of presentation. So I chose a very interesting topic to talk about is metastatic castration-sensitive prostate cancer. And I chose a presentation of Dr. Fisasi that he presented about the new strategy in this field. This is a very interesting topic to address because it's a moving field. And as you know, there's new strategy that wants to intensify the treatment of castration-sensitive metastatic prostate cancer that involves the ADT to another agent. In this case, could be the chemotherapy, docetaxel, or the new androgen receptor target therapy, as abiraterone, enzalutamide, or apalutamide. There are at least 7 large clinical trials that show the benefit with this strategy, not only as a statistically significant, but also clinically significant. And this benefit was maintained over time. So there are practice changes in many ways. So when we have to consider for the treatment, we have chemotherapy on one hand, and on the other hand, we have hormonal therapy. So toxicities are very different in this, and you can manage differently. So we have to look for other factors just to consider what to choose. We have to choose our overall survival, PFS, the volume of disease. So this is the number of metastases that the patient have, the risk factor as a Gleason score or the PSA value. Also, if the presentation of cancer is de novo metastatic or is a relapse, that this is very interesting because in our region, in LATAM, we have a very much incidence of de novo metastatic because maybe influenced because of the lack of screening program or delay to consult to a medical doctor. So these options that we have in the situation of the disease that have demonstrated benefit, not only in overall survival, but also that is, from my point of view, the very important endpoint, but also has improved in quality of life. It's a very improvement in the quality of life, even though we have to use chemotherapy for this patient. Especially in the pain relief was very important, the improvement of that in this situation. But at the end of the day, we have to choose how to choose the treatment for this patient. Especially in our region, we don't have to forget about cost and the availability of these drugs. Chemotherapy is always available; it's very cheap and it's reimbursed for in many countries. But the new drugs, the new targets, anti-androgen therapy, it's very very difficult to achieve of them. So I think that the most important thing here is just when we have to decide for the treatment, we have to share decisions with our patients, and also we have to try to discuss the patient situation in a multidisciplinary team. In our region, this is the most important thing because we have to look for the best strategy for the patient at this time.
Thank you very much. So if you take the content of the ESMO 20 educational weekend, how would you treat as first line those patients? The metastatic, castrate sensitive or resistant prostate cancer? How ideally you treat and what is available in your country? How can you treat nowadays?
Dr. Fisasi, in his conclusion, says that the new standard of treatment is going to be a new hormonal agent, but in our region is not available always. These drugs are very expensive also, and there are not reimbursed in many countries in our region. So at the end of the day, you have to decide for chemotherapy that is not inferior to other regimen, although it's not compared to the new hormonal agents, but you have impact in other factors as the 6 cycles is going to decrease initially the quality of life, and then later is going to be better the quality of life. So adapting this to our region, docetaxel is going to be the most indicated treatment.
Yeah, I don't know if any other of the panelists can comment. In your country is also this problem of not having available an endocrine therapy for prostate cancer. You should give chemotherapy as first.
Well, I can say that from my colleagues from GU, they also told me that they have problems with the reimbursement of these expensive drugs. They are here in Mexico, are available, but not everybody could get it because of the different social security that they could have.
Thank you. I think in Brazil as well, Brazil is a heterogeneous country. There are privileged hospitals and centers that made available for their patients all kinds of cutting edge drugs. But on the other hand, the public system, unfortunately, patients do not have access.
Yeah. Thank you, Leticia. Andrea, you were saying that there was similar situation in Peru.
Yeah, actually, I have a family member who has metastatic prostate cancer, and yeah, we face the same issue. We have to do paperwork 3 months in advance in order for this family member to get a abiraterone, and due to the pandemic, the paperwork is going slower, so much that we have had to buy it ourselves because the Social Security is very slow in order to give them the medicine, and there are many types of Social Security, so yeah, it's very difficult.
Very heterogeneous in different countries.
Can I say something else? Maybe just as I was hearing the rest of the people here, the best option for our patient here maybe is to include it into a clinical trial. Maybe that's the best access to new drugs in our region. So we are always trying to look for a clinical trial in nearby, just to include the patients.
Yeah, this is indeed a very good comment. Clinical trials are always a possibility for patients to get new drugs faster. Yeah, indeed. Yeah. Thank you very much. Let's move to Leticia de Mattos-Arruda. She's going to talk about liquid biopsy. She's specialized in liquid biopsy. So what did you learn from the ESMO 20 educational weekend?
Hi, Ivan. First of all, thank you for the invitation, and thanks ESMO for bringing us together here today. So I've chosen a translational topic like liquid biopsy, and because I think the potentials of liquid biopsy, particularly in regions like Latin America, where everything's so difficult, is that, and the medical infrastructure is limited, so liquid biopsy could perhaps eliminate the need for surgical biopsies. So what I revised and learned from liquid biopsies in the ESMO educational weekend was a very nice talk presented by Clara Montagut from Barcelona. She spoke about circulating tumor DNA in colorectal cancer and whether ctDNA can be used for monitoring or to predict changes in therapy. So the clinical applications of circulating tumor DNA in metastatic colorectal cancer are at least 3. First, to detect mutations as biomarkers, for instance, KRAS, BRAF, macrosatellite instability. All these markers, they have high concordance between tissue and plasma. Second, to monitor tumors and the tumor dynamics over time. And third, tracking resistance. So liquid biopsy can detect early the emergence of resistant clones in patients with anti-EGFR monoclonal antibodies, and studies have shown that liquid biopsies anticipate a clinical radiological relapse in 4 to 5 months. So, and once patient has progressed, ctDNA can tell which are the mechanisms of resistance. So KRAS mutation was seen in 30% of the cases, EGFR 25%, BRAF 7%, c-MET and HER2 amplification in almost 3%. So a last point I'd like to make is about rechallenging or adding again anti-EGFR therapy in patients that already received, and what is the role of circulating tumor DNA discriminating which patients are going to benefit or not. There is an interesting study called the Kronos, that is aimed to use liquid biopsy to identify colorectal cancers that originally responded to anti-EGFR therapy, who can then benefit from a rechallenge. So patients, they would receive a second round of EGFR blockage based on KRAS or BRAF ctDNA kinetics. So currently it's the metastatic setting where liquid biopsies may provide the best opportunity for the clinical utility. But of course, we still need some phase 3 clinical trials to see the expansion of the uses of the applications of liquid biopsies.
Okay, thank you very much. This is a very important topic, Leticia, and because if you could use ctDNA, which is easily accessible, you just do a blood draw and you can assess mutations, you can see resistance to treatment, you can see many things in that. which is much easier than doing actual tumor biopsy. So this would be an advantage. Do you think this technique could be soon available in many countries where you could test resistance or sensitivity to new treatments or even to standard treatments for our patients?
So I think we have to fight to bring this to the patients in other parts of the world, because this would help them to receive the correct treatment and not have the burden to make them perform a very recent biopsy and not rely on an old biopsy. And also there are patients that are not fit enough and they not have an easy way to perform a biopsy. So I do believe that this is going to be, and this should be the clinics all over the world in the next few years.
I agree with you too, because tumor metastatic cancer is very heterogeneous, is a dynamic thing. When you change treatment for progression, you may find other mutations that were not there before. And if you do just a biopsy of tumor 2 years ago, does not represent the metastatic tumor of today. So I think this to see this dynamic of change is very important for patients. How is the liquid biopsies in other countries, like in Argentina?
In Argentina, it's for GU tumors is not yet available. Some GI tumors for colorectal cancer is available for the KRAS mutation detection, and it's approved here, so you can test it. But I agree that it's very important to have this into the clinic, because especially for castration-resistant prostate cancer patient that mainly have a bone metastasis, that it's very hard to obtain a tissue, and also the processing of the sample is going to be very hard to obtain DNA. I think the liquid biopsy is going to be a good tool to use in the daily practice, no?
Mm-hmm. And how about Mexico?
Well, at least for GI, we have settled down in for PRAS, BRAF, and also for the rechallenge, as already was said. But I think that the most important, well, I think that another uses are going to be as in the adjuvant treatment, because, for example, you all know that for colon cancer, stage 2, normally we give chemotherapy if there are some high risk factors. And nowadays they are running some trials trying to know if the ctDNA is positive, give chemotherapy, even though if there is not high risk factors, or just the opposite. If there is not, if the ctDNA is negative, trying to avoid the chemotherapy. I would like to say that there are some disadvantages about the liquid biopsy, and most of them are methodological and technical issues. So hopefully, if this could be resolved, we could use it and in all these scenarios that has been talking already, because liquid biopsy could really will help us to take better decision in favor of our patients.
I agree. I think there are false positives and false negatives, and we as clinicians, we should be able to interpret it properly. What is the result of a liquid biopsy? For instance, a false negative, it means that it does not mean that the patient does not have the mutation. So we have to go back to the tissue and double check. This could be because of low sensitivity of the test. And a false positive could be that the mutation detected could be coming not from the tumor, but from the white blood cell.
And the other important thing, Leticia, related to what you said, is that maybe we could have a lot of mutations, but sadly, none of them are actionable. There are no drugs to work into these mutations. So now we are facing that we know a lot of the genetics of the cancer, but maybe we will not be able to give a drug for that specific mutation.
Yeah, and I think this is a point that I would like to comment, but particularly where you have drugs targeting mutation like PI3K. If you do not have the PI3K mutation in ctDNA, you should test in tumor. You should not prevent giving the patient a treatment if the patient has a PI3K mutation in the tumor. So I think that's an important message. Yeah? When you have a target agent, you really need to look for the target for the mutation. Okay. Thank you very much for this discussion. Very interesting. Let's move to our last but not least speaker, Andrea Anampa-Guzmán from Peru. As I mentioned before, she's not an oncologist yet. She's a medicine student, very motivated in cancer, passionate, as I could see her discussion before. So, Andrea, we are going to talk about cancer policy.
Hi, thank you very much for the invitation. I'm going to comment on the talk by Dr. Rosa Giuliani, cancer policy, and what it is and why you cannot work without it. I think it was something very interesting to show the collaboration between ESMO and the WHO, the World Health Organization, and how they are working together to create a health equity access to optimal and sustainable cancer care, focusing on cancer prevention, treatment, palliative care, and support to survivors. We don't have something like ESMO in Latin America. We have PAHO, that is the Pan American Health Organization, which serves as the regional office of the Americas for the World Health Organization. And it looks over the whole Americas. So it's not something just for Latin America. I really like they set goals and resolution. That ESMO was recognized by the World Health Organization that were very defined, and they were working collaboratively to develop a national control plan tool and model our the recommendations. And for example, one of them was to control cervical cancer by accelerating the global vaccination. And they even have a specific case that they presented that was the country of Kazakhstan, in which they included in their national care plan the recommendations of ESMO and WHO. Latin America is more, I think, is more diverse. Is composed of many different countries. Every single country has their own cancer plan. As an example, in my country, in Peru, we have something called Plan Esperanza that started in 2012. And what it meant is that it was a care plan to improve access to cancer services. It was mainly targeted towards prevention, screening, and treatment. And they don't include survivorship. This cancer plan is national, but it's only targeted to people of very low resources and with a specific type of cancer: cervix, breast, colon, stomach, prostate, leukemia, and lymphoma. I don't know if my fellow discussants can talk about their cancer plans in their own countries.
Okay, very interesting. And I think you touched something that is very important, is screening and prevention. I think it is fundamental because we are seeing a lot of cancers and many cancers can be prevented. So I think ESMO is doing some work also in prevention nowadays. And I think it is important that you bring this to council, because if you cannot give the best treatment for cancer patients, if you can prevent the cancer, is already a good thing. So I think it is very important, early screening and prevention. So how is the cancer plan in other countries like Mexico, Erika?
Well, we have, since 2 or 3 years ago, we established a cancer control plan. These have changed a little bit in the last year because we changed of government, so they bring new ideas. And nowadays with the COVID-19 pandemic, all the plans that we have for the care of the cancer patient have changed. So I think this is happening in the whole world, but we now have a lot of delay in diagnostic and also in treatment. but I think that it's very important to establish policies, because that's the only way we can change the prognostic of patients. You already said, Evandro, maybe we cannot be able to give the best treatment or the best technological issue like the liquid biopsy, but if we could prevent, that would change everything.
Yeah, I fully agree with you. And you have really to work in the prevention. So the increase in cancer, increase the changes in lifestyle, increase obesity, these are the main factors that you really need to target, and you should be targeting very soon. Yeah. How is in Argentina, Martin?
Yeah, the same as the rest of the Latam countries, but I think that I agree with you also that prevention is the best thing, and one of the best thing that Argentina did was to include into the national calendar of vaccination the HPV vaccine for all girls since 2011, maybe if I'm not correct. And after a few years later, they included for boys also. So I think that's the best way to prevent and just to reduce the cancer burden in our country and in our region also, the prevention. So we have still some lack of screening program, but we are working on that, and maybe we'll see some cancer reduction in the future.
Yeah, thank you. Erika mentioned something very important, and I'm going to ask a short question to all of you, short answer. So how the COVID has impacted, the pandemic has impacted cancer treatment, cancer prevention, cancer screening programs? I'll start with Leticia.
I think COVID has made an incredible change in all senses, in all aspects of our lives. And for cancer patients, it's retarding them to reach the clinics, retarding them to receive good treatment, and retarding them to be aware that they have to receive the treatment.
Yeah.
So.
Yeah, thank you. Andrea, you want to say something about this COVID pandemic?
Yeah, we were already very delayed in our vaccination goals of this year and the previous year. So, and now we are facing this challenge again because we cannot even get the COVID vaccine to all the healthcare workers. And as Dr. Mattos said, we are seeing patients that are coming with more advanced cancers, and it's very difficult to refer them because many hospitals are only seeing COVID.
Yeah, okay. Martin, last final word on your side from the COVID. How is
the same? Maybe the same as the word of the rest of the world. Every patient delayed, huge higher volume of tumors. So yeah, that is changing thing, hopefully.
Yeah, okay. So I think we had a lot of discussion today, very interesting. We discussed many topics about circular tumor DNA, treatment for prostate cancer, also public policy, and how we do treat pancreatic cancer. I think there is still a lot of work that we as oncologists or students, we have to do. We are here trying to learn things. ESMO is here to help us to learn things and try that you can bring this information, innovation closer to our patients. And I think this is a good thing. So I would like to thank all of you for your great talk and discussion. I would like to thank you, ESMO, for this great initiative. I think it's very important to focus in Latin America and to focus in other areas as well. And I would like to thank people who is going to watch us at home. And I would like to say that this content is available in the Oncology blog from ESMO. Thank you very much and have a nice day.